Okay, so it's about time to start. It's a tough one for Amsterdam because it's just after lunch, but we will try to manage. I think for the remote, it's probably easier. So my name is Louis. I'm a developer at FHIR, and it's my pleasure now to introduce Uri. He will speak about, I guess, the challenges from moving and remodeling the medical report to FHIR. So Uri, the floor is yours.
Okay, thank you very much for having me. So we don't have much time, so I'll start right there. And again, my name is Uri. I'm coming from Israel. Right now, speaking from Israel because I'm virtually here. And I'm project manager in Maccabi Healthcare Services. Okay. I'm a project manager in Maccabi Healthcare Services, which is one of the health organizations in Israel. I belong to the medical informatics department. I'm not from the technology division, but I sit somewhere between technology and clinical sides, working on all things FHIR, terminology, data modeling. And I'm also Maccabi's representative within the Israeli core work group. So you can reach me here on Wova or by email or LinkedIn. All my details are available also at the end of the presentation. What are we going to talk about today? I'll tell you briefly about Maccabi. Because nobody really knows the Israeli healthcare system unless you live here or work here, and a bit about our work, our strategic roadmap for FHIR and the projects we're doing. And I'll focus shortly on modeling diagnosis from our legacy data systems to FHIR. So Maccabi, as I said, is an Israeli health organization and health maintenance organization, the second largest one in Israel. We have over 2.6 million members, 6,000 physicians, and we have one of the unique features is that we have almost over 20 years of patient data digitally within our EMR, and all the medical functions from physicians to nurses to clinical aspects and dietitians and everybody else use the same EMR, so the data is unified. Speaking about FHIR, when we started talking about FHIR in Israel and specifically in Maccabi, we understood that the first step is to try and understand the business itself. Before talking about the data, we just need to understand the components of our medical record. What do we have on the clinical side? What on the administrative side? Which services write and read from the EMR? And before understanding business aspects, we can't dive into the technological aspects, which is, of course, the second step. Understanding the data. We have various data sources, both within the organization and data coming from outside, which I'll explain a bit later. And we need to understand all those data sources. What comes from every location, which data types, what terminology, and without doing a proper work at that stage, we can't move forward. The third step, once we know what are the sources and what is the data, we need to understand how to represent the data. And of course, we want to do it FHIR. But I'll put a small icon here, which is say it's an adapted FHIR representation because we have limitations that arise from our business side, from our clinical workflows, and from the way data is represented today. I'll explain a bit shorthand. We'll call it MacFHIR, but it's basically convertible to FHIR on the fly. So it's just some small adaptation that we need to do inside Maccabi. And of course, the final result we aim to achieve is a highly flexible, interoperable data source within Maccabi that's available to everyone who needs it, specifically and most wanted the patient, but also everybody else who has access to the data. So what's the general approach that we chose? We chose two sides. One of them is working on small-scale projects, time limited, very little effort compared to the bigger ones, but with some gain, understanding one FHIR structure, one interface, one small issue we had with the previous data that we want to solve. On the other hand, we want to think big and we want to think long-term. We want to think wide scope. We want to represent our data structure from our legacy system as FHIR resources, which is something huge when we're talking about 20 years of various data, but we need to start somewhere. So we chose a few projects, smaller ones to start with. If it's getting digital prescriptions from hospitals to Maccabi's community facilities, if it's talking about wound assessment in collaboration with an Israeli startup company. And we thought, on the other hand, on which FHIR resources or which medical domains we want to start with to represent as FHIR, with diagnosis being the first one, allergies to follow, and referrals down the chain. So as I said, the first step is mapping and understanding the data source. So now, talking only on diagnosis within our EMR, we have few different data sources. The first one is, of course, the EMR itself. When a physician encounters a patient, he can save a diagnosis either one time, like a headache, or he can save something which is more constant or active, like diabetes or like asthma, which goes from encounter to encounter. But also, the physician can recommend some expensive medication or some expensive treatment. And then we have a special financial department that looks on this request and authorizes it and saves the diagnosis within these claim authorization, which is also another source of diagnosis within our data systems, but it's not a clinical one, but more of a financial one when we try to think about it. The last source of diagnosis we have is coming from the outside. We have diagnosis coming from hospitals. When a patient of Maccabi goes to a hospital and comes back, we get his summary of his visit, we get the clinical data, but also the company bills Maccabi to pay for his visit. So we get it both from the clinical side, but also from the financial side. Each of these reports includes the patient's diagnosis, of course, because we need to know why are we paying or what is the continuity of care? How do we need to keep on treating him? So we understood the sources, we did the mapping. Now we need to start and understand the data. So looking on our EMR only, we have about 55 million yearly diagnoses encoded within our data within our EMR. The coding itself is not, unfortunately, not international terminology. It's using something we have locally, which we call Y codes. It's convertible to ICD-9 or all ICD-9. And these diagnoses also can include modifiers, which are attributes, which I'll elaborate on a bit later. And diagnosis can be deleted, it can be updated if something changed. And most of the time, it's not confidential. It's something that every physician can see in the patient's file. Financial side, those claim requests and the authorization for medications, we talk about nearly 1.5 million diagnoses every year, also coded within our system. You can't delete one because once you approved the medication, the diagnosis is there to stay, but you can update if the patient's clinical status changes. Also, we have the data coming from the hospitals, both the clinical one, which the code, the terminology can change. It can be canceled, or the hospital can report us that it was entered in error. There are also situations where it's confidential by Israeli law. For example, if a patient who's under 16 years of age has undergone an abortion, the data is considered confidential, and then we get the flag that says so, and we need to keep it. And also we have the billing reports for different operations that our patients undergo in the hospital. Different codings, ICD-9, 10, modified ICD-9 for the Israeli version, and even other codes that sometimes we don't even know the code system when we get those billing reports. So as you can see, the numbers are different. And when we try to look at the data and understand what's the overlap and can we use synchronization between different data sources and try to see what's the real truth, it's quite of a problem, because even within Maccabi, looking at the EMR and the financial side, only small part, because most diagnoses are not relevant for claims authorization. Data coming from the hospitals, sometimes there is no bill being sent because someone else paid for the service for any reason. Sometimes the billing arrives and there was a problem sending the clinical data because of technological issues, and then there are some missing data over there. So we needed to find a solution to identify those different sources. If a diagnosis is the same one based on date, department in which hospital the patient went through, then we need to, of course, understand not to do double reports, double diagnosis saved, but the picture is not so easy. Now let's talk a bit of a FHIR. The way we represent diagnosis is using the resource condition. And I want to talk to you about the fact that the issue we faced and the decision we took on the first step was that we're going to use FHIR. We're doing what we call FHIRizing the data, but we can't interfere with the process, the clinical side, the business workflows that our physicians used to work with. And because of the fact that we can't interfere, we had to compromise in some places And that is why I talked before about, we called it an adapted FHIR or a Maccabi version, which allows us to use our regular data structure or knowledge we have, but working with the recommended structure as FHIR and create something which is convertible to FHIR upon request. I'll give you a small example. The list you see here, all of these values, what we call them in Maccabi modifiers, they're actually characteristics or attributes that can be attached to the diagnosis. Let's say if a patient has a fracture in his left leg, then the physician can add left. He chooses the diagnosis of fracture, adds the definition of left, and then it stays like this in our data source. You see, it's a bit of a complicated list. We have two fields for modifiers, modifier 1 and 2. There is no priority, which one is more important, and they all go in the same place within our data systems. Now we're thinking about FHIR, and looking on the resource of condition, we have here few different fields. Each of them matches some values in this list. Let's look on body side, for example. We can see it covers right and proximal and bilateral, and even caudal or upper or lateral. It works. Clinical status also represents part of this list. Of course, severity and verification status, and eventually we managed to cover the entire list of modifiers we have within Maccabi using 4 fields that are native to the resource FHIR condition. We don't need to change anything. We just need to assign on the conversion process that we do when we save the data from Maccabi system to FHIR. We need to know in which places to store them. Easy, right? However, it's not that important, not that easy, because all of the list, the value of clinical status that you see down here, the binding is required, which means we can't put any value that we want. We have to use active, recurrence, relapse, inactive, remission, resolved, or unknown. We can't use all of these. But the power within FHIR and the process that we did is that when looking on this list, all of these actually we can translate to active. And because clinical status is a codable concept, within this codable concept, we actually used 2 codes. The first one was active because it is required. And if someone wants to reach and get this FHIR resource, he will get the status active. But we also added the second value of these. And along the way, we also took each one of those that were actually not coded within Maccabi and attached the SNOMED code to them. And now we use the SNOMED CT term with the correct one in addition to HL7's one active. So when we save a diagnosis as FHIR within our data systems, it has first the actual the required binding from here, but also added data. And we also translate it to a common terminology and accepted one, SNOMED CT. And that way, if someone needs this diagnosis, it's much easier and much smarter. Unfortunately, it's not that simple. And when I said that we had to adapt FHIR a bit, is because there were situations where a physician chose both, let's say, acute and complication. Actually, he chose 2 modifiers. Both of them are representing clinical status. Clinical status is only one place and is required. We can't use both. In this particular situation, we added some small extension, which allowed us to use a second clinical status, a secondary clinical status, understanding that when someone will approach the resource and look for the basic common default structure of condition, he won't receive the second one. We had to prioritize one, use active, use the first one, and the second, internally we can use them, externally it's there if you know what to look. As I said, FHIR does not stand alone. And when we started working on FHIRizing our data structures, we understood that staying with local codes and staying with our basic workflows and approach won't be really a good work. So we also initiated a wide-scale terminology change. We're moving to SNOMED CT and we're moving to LOINC wherever possible along the way when converting to FHIR, when saving FHIR structures. We also entering data quality monitoring within the system, automated processes to see if the conversion is correct. We talked about the overlapping between the different data sources. So on the conversion to FHIR, we also run some quality assurance processes to understand the differences, to try and understand and find if there are any problems. And we elevate the effort of going into FHIR to correct other problems, to improve other problems. So if trying to summarize this short presentation, a good FHIR implementation is the key for good outcomes. Starting correctly from mapping, looking on the complete picture of the business side and all of the tech aspects, all of the data and the differences in data and all the small knickknacks, that's the only way to achieve the result we want. But there is also always the issue of balancing efforts and the resources we have. As I said, the big, long, wide project of representing the FHIR structure or smaller projects, we need to balance them in order to get the better gain. The last point is that there has to be a multi-expert cooperation. I work, as I said, in the medical informatics department. We work between the physicians, between the clinicians, and the technology division. We, of course, had a very good cooperation with the clinical side. We worked with physicians. My department manager is a family physician, and the understanding the medical record from physician sides and the workflow and the process that they do is mandatory. And of course, we have to have a very good FHIR team, a very good digital team. In this place, Maccabi works with Outburn Ltd, which Daniel represents over there in Amsterdam, in trying and understand correctly how to do it correctly, the FHIR structure, how to convert it correctly, how to use the condition resource the right way, and of course, other resources in other projects. So this multi-expert cooperation is something that we're pretty proud of because that's the only way we could achieve such a huge goal. So thank you very much. As I said, I'm here for questions. I'm here on Wova and LinkedIn, and my email is open. And again, thank you for having me.
Thank you. So thank you, Uri, for this example of FHIRing. What did you say? FHIRing the Maccabi system. So, so the plan is I will take first the question from Amsterdam, and if there are some, I will also look at the question from Hoover. Any question here? Yes.
Thank you very much for your interesting presentation. You've mentioned that you represented the data as medical record adapted FHIR representation, but what you've shown us after it was just FHIR, not adapted.
Yeah.
So what do you mean by adapted FHIR representation?
Okay, as I said, I'll go back to this one. The codable concept for clinical status allows us to use only one modifier of the family clinical status. And the list here, acute, atypical, chronic, we saved active because it's from the required binding, but we also saved the acute or the chronic as a second value within the codable concept. So far, it's FHIR, no difference. The problem is that physicians in Maccabi don't know FHIR, and sometimes they don't think that one clinical status is enough. So they can write a diagnosis and give it two modifiers that are both clinical status. For example, a follow-up visit for the complication of diabetes. So they'll give a diagnosis of diabetes mellitus type 2, with one modifier will be complication and the other modifier will be follow-up. Both of these translate to active and to within the clinical status field. And then the question rises, how can we encode it within FHIR since we allowed only one? The solution that was chosen within our technology division is adding a small extension, we call it secondary clinical status, in case one is needed. And then we save as the clinical status, we have complication, which is more important because that indicates the reason for visit. So we have active and complication within one codable concept. And we have a second field called clinical status secondary, which is himself is also a codable concept that has active as required and follow-up as a second value. Now, if a system that knows how to read FHIR will approach Maccabi's FHIR server and request will get condition for that patient, he will get only the basic values for the condition, the first clinical status. He needs to know that there's a secondary clinical status in order to get it, and it's up for a decision within Maccabi if we even get this data outside or we keep it only for the internal systems. So the basic is FHIR, and it's FHIR compatible, and it can be converted on the fly to FHIR. But we have some small adaptations in cases that the way clinicians work is not exactly the one that was the basic for FHIR. I hope it answers the question.
But I think we are running out. I will take one, but then maybe the next one you can ask on Wover because we
are out of time, so we'll need to move on.
Okay, so even both will be on Wover then. Okay.
Thank you again.
Thank you again, Uri. And then I said, so the video will be available within 1 day. And please provide your feedback and ask your question on Wover.